we are going through a case of rhinoscleroma with oral and nasopharyngeal manifestations. This is a case report where the patient came to the ENT OPD of MIMS. We examined the case, subjected the patient for various investigative procedures, took the help of our pathology faculty, diagnosed it and treated it with the most recent update in the medical conservative therapy for rhinoscleroma. So, the patient we are discussing about today is Mr. Ravi from Orissa. He is a 36-year-old male, a laborer, came with a chief complaint of nasal obstruction since a period of 4 years, which was insidious in onset and gradually progressive. The patient also had a history of epistaxis since 1 year. It was intermittent and moderate in quantity. The patient had anosmia, that is absolute lack of sensation of smell, and a facial pain more on the left side since 6 months. The silver lining here is the patient had a habit of bathing in ponds. On clinical examination, when we subjected the patient to for anterior rhinoscopy, multiple nodules were seen in both nasal cavities, bilaterally in both nasal cavities, and on posterior rhinoscopy, multiple nodules were seen in the nasopharynx, and the extra thing which we found out was the posterior nares or the choana were heavily cicatrized and fibrosed. They were very narrow, leading on to a pinhole choana. On diagnostic nasal endoscopy with a 0 degrees nasal telescope, bilateral nasal cavities had multiple reddish nodule-like things, and apart from the nodules, we could also see a little bit of cicatrix going on in the posterior nares or the choana. The similar lesions were seen in the nasopharynx and oropharynx also. On diagnostic nasal examination, these were the pictures where we can see in the right nasal cavity multiple nodules could be seen on the septum and on the right inferior turbinate, whereas in the left nasal cavity similar nodules were seen on the middle turbinate, on the bulla and on the inferior turbinate also. In the nasopharynx, we could see the lesions at the posterior nair, and at the same time we can also see a narrowed choana, a narrowed posterior nair. In the oropharynx, lesions were seen on the pillars, that is a posterior pillar and the anterior pillar. This is the base of tongue, this is the posterior pharyngeal wall, this is the posterior pillar, and this is the anterior pillar. So lesions were seen on the anterior pillar and the posterior pillar also. So when we subjected the patient for investigative procedure, we took a biopsy from the nodule and sent it for histopathological examination to our pathology department, and it was reported as containing a collection of lymphocytes, plasma cells, foamy macrophages also called as nucleic cells, some hemocentral macrophages and congested blood vessels. All these features were suggestive of a rhinoscleroma. This is the histopathology report furnished by our pathology faculty. So after this particular diagnostic evaluation, we came to a conclusion that the patient has got a rhinoscleroma, a lesion characteristic of rhinoscleroma. The cliché here is that there are various stages of rhinoscleroma, and this patient presented with overlapping stages of the disease. We will discuss all those things when we go to the theoretical part, but the cliché here is the patient has got overlapping stages of disease. We referred various textbooks, various journals, various printed materials, the recent advances, and decided to start the patient on a conservative medical therapy. That is, we started the patient on intensive antibiotic therapy for 8 weeks, rifampicin 600 mg once daily, Septin twice daily, and ciprofloxacin 500 mg twice daily. And the patient was followed weekly for the first 1 month and then fortnightly from then on. Results. So how were the results with this new recent advanced therapy? The nodular lesions completely regressed in the nasal cavity, nasopharynx and oropharynx after taking this intensive antibiotic therapy. Where in these pictures we can see that there's complete absence of the nodular lesions, which we have already seen. So this is for comparison. In the first slide we can see the lesions, and in the second slide the lesions are completely absent. The patient was regularly followed up to 1 year. 2 consecutive histopathological examinations from the surface of inferior turbinate and the septum were proved to be negative. This was given in the latest book that 2 consecutive histopathological examinations, when proven negative, that demands complete cessation of the therapy. There were no signs of recurrence. The patient was comfortable. Now coming to the discussion, the boring theoretical part. Rhinosclerosis is caused by gram-negative bacillus. It is a chronic infective granulomatoous disease. Now what I was talking about the different stages of rhinoscleroma. Rhinoscleroma has got 3 stages. First is an atrophic stage where the mucosa, periosteum, bone of the turbinates and all, they get atrophied. And the second stage is granulomatous and cicatrizing. So coming to the conclusion, this report presents a nasal, nasopharyngeal and oropharyngeal rhinoscleroma with overlapping stages of the disease. The patient had overlapping stages of the disease, and the patient was kept as a combination antibiotic therapy, and the patient was comfortable post-therapy. Thank you.
Thank you very much, Dr. Manohar. The paper is open for discussion.
What is the cause?
Chairman is having one question.
One simple question I would like to ask. Since this is an infective disorder, why those 3 antibiotics were chosen where they are not particularly so much known for anti-clepsydra action?
Yes, ma'am. Yes, ma'am. Actually,
So there are more specific antibiotics for particularly for clepsydra. What they were not?
when we referred the various textbooks and printed materials, ma'am, we had like evidence-based. It was like we had a evidence-based medicine that these antibiotics are acting properly, and we have around 4 or 5 cases where those patients were responsive to these antibiotics. We didn't want to take chances because the patient had already gone into a cicatrization stage. If we had taken chances for 2 to 3 weeks going on with what like a trial method, the patient will go into a complete cicatrization stage and the posterior nerves will be completely closed. They were already being closed. So what we did was, we did a little bit of research, looked around and found out that, yes ma'am, I accept ma'am, I accept ma'am. But by evidence, that particular treatment was proven, and we have proved in this particular case also that the lesions have completely disappeared, and a blind biopsy from the inferior turbinate was also negative post-therapy.
Please.
Another question, if you don't mind. How common is this disorder?
Rhinoscleroma was actually a little bit more common around a decade or 2 decades back, but now the incidence has come down to around 4%, 4 to 5%, and more when it is because of unhygienic conditions where the patients bathe in ponds where buffaloes and cows are also being washed, and because that practice has been lost now, it is seen in too much a rural area. So obviously that particular incidence has gone down. We are not seeing much of cases. We are not seeing much of cases.
My suggestion was, in future, if cases come in early stages, why not to try and get
Sure. We will come back.
Thank you, madam. One more question from HOD.
Madam, sir, the causative agent is not Klebsiella pneumoniae, it is Klebsiella rhinoscleromatis.
Yeah.
So the sensitivity pattern differs.
I put it as rhinosclerosis.
The sensitivity pattern differs. This organism scleromatis is sensitive, whereas pneumonia is quite resistant. When did you do the follow-up? Means that what durations and how many follow-ups have you done?
For the first 1 month, the patient referred to us every week, and then every fortnightly for 6 months, and after that every month for up to 1 year.
Okay, that's good because we don't get such big follow-up. And what does literature suggest about the recurrence?
Recurrence, it depends, ma'am. Like going by what the literature says, there is nothing called recurrence for a rhinoscleroma. There is something called residual disease, where the patient didn't use the treatment properly, the patient was lost to follow. There is nothing called recurrence. That is why we made sure that the patient has got 2 negative biopsies. in literature we didn't find any cases of recurrence.
No, what I meant by recurrence is like failure of treatment and all that stuff.
Yeah, failure of
Further discussion at the time of our lunch. Thank you very much. We'll
Biochemistry department. So my topic is the role of vitamin D as a causative of insulin resistance and pre-diabetes. Before I go, I would like to thank my colleagues Dr. P. Hari Babu and D.S.S. Raju who were there with me throughout the study. So what is this? Diabetes mellitus has become a worldwide problem and the complications have become so severe that anywhere you go you find many complications of diabetes more than the disease itself. So there is a term called pre-diabetes which may progress to grand diabetes by 18% as per Indian Diabetes Prevention Program, and again there is saying that every unit increase of vitamin D in the body is associated with a 5.4% increased chance of reversal to normalcy of the elevated blood sugar levels as per International Society of Endocrinology. Keeping these 2 points in mind, we have taken up the study to study the prevalence of vitamin D and its association with insulin resistance in developing for pre-diabetes. So let's see what is the association between insulin resistance and vitamin D. Now vitamin D mostly acts through the vitamin D receptors. Now it influences the beta cell function through vitamin D receptors directly or through calcium mechanism indirectly. It also improves the insulin sensitivity in the target tissues like the adipose tissue and the skeletal muscle, again acting through the vitamin D receptors, and it improves the beta cell function by protecting them from inflammation like the release of cytokines and all. And fourthly, gene polymorphisms which mainly affect the vitamin D binding protein as well as the vitamin D receptors, and also an important enzyme for the formation of vitamin D totally, that is the 1-alpha hydroxylase. These not only affect the production of vitamin D but they also influence the insulin release. And finally, the vitamin D inhibits angiotensin 2 which is supposed to act as a vasoconstrictor. This is totally the action on the gene transcription, and when this is defective, there is definitely insulin resistance. So coming to the materials and methods, we have just chosen 150 students, of which 32 were normal and 38 were diabetic. So we have excluded all those, and 80 cases were chosen which showed that they were pre-diabetic, meaning that the fasting blood sugar levels were 100 to 125 milligrams. That is not established cases of diabetes, and the post-prandial blood sugar was between 140 to 199. So we have performed OGTT, the oral glucose tolerance test on all these. Then 6 turned out to be normal even on repetition. So we had to choose only 74, out of which 4 were absconding and 70 were chosen for the study. So we have excluded all the people who were on insulin or oral hypoglycemic agents, calcium, D, vitamin supplementation. So all those things which would influence either the vitamin D or the blood sugar levels, those were all excluded. And chronic diseases like the kidney disease and the liver disease, endocrine disorders, all were excluded. Especially we took care to see that BMI was not greater than 25 in any one of the patients, because obesity or overweight can itself cause insulin resistance. So by different methods we have estimated the plasma insulin level, the plasma glucose level, and we have calculated the insulin resistance basing on the formula, that is the HOMA-IR glucose into insulin by 405 to get the value in milligrams. Now this is how we have tabulated our results. We have divided them into male population and the female population, and among the male population we have again taken 2 categories, high insulin resistance and moderate insulin resistance, 20 and 15 respectively. When you observe, you see that the insulin resistance and vitamin D in both the cases had a negative correlation, but the high insulin resistant cases, the insulin resistance was very high, and proportionately the vitamin D levels were very low compared to the moderate insulin resistance, and this negative correlation was very significant. When we observe this, suppose you consider this category of 15 patients having a vitamin D in moderate deficiency 10 to 20 nanograms per ml, we have seen that 12 are having high insulin resistance, whereas 3 were showing insulin resistance but not as much as the high insulin resistance group. The same thing in the female population. When we observed that the insulin resistance was high in high insulin resistance group and the vitamin D levels were proportionately very low. So there is again a negative correlation in both the cases, and this was very significant. The same could be studied here, where we can see 19 patients when we consider the 10 to 20 nanograms per ml, 14 were showing high insulin resistance and 4 were showing relatively lower insulin resistance. So our work was supported by 3 studies majorly. The Redka et al. Who have said that vitamin D supplementation could reverse the chance of becoming a total diabetic by 8%, and the reversal was effective up to 5.4% in pre-diabetic cases. And Burr and all suggested that 25-hydroxy vitamin D levels, they are independent risk factors for insulin resistance. So Scratch et al. Also have shown that IGT or DM patients had very low 25-hydroxy vitamin D levels. So these are the methods by which the vitamin D deficiency causes insulin resistance, which I have already told you. So to conclude, early detection is important because pre-diabetes could be stopped from progressing to frank diabetes mellitus either by supplementation or by early onset of treatment. These are my references, and thank you.
Thank you very much, madam.
Conclusion of the study.
It was over a period of around 3 years because we had to get the cases with the low BMI but still insulin resistant.
And what was the age group?
The age group, they randomly have taken from 20 to 45 years.